Okay, good afternoon everyone. My name is Mike Murphy from the MRC in Cambridge. And myself and Christiaan have been volunteered by Josiane to look at this round table. And so Christiaan and I had a bit of a chat about how to do this. And what we think is best to do is try and encourage people to ask questions. And we've got a few questions to get us going. But could the students put their hands up, please? PhD students? I'm on the students here. Okay, now I know who you are. You all have to ask questions, please. All the students have to ask questions. I can see who put their hands up, so we're making sure you ask questions. What we want to do is try and cover the topics of nutrition, epigenetics, metabolism, and stress. And luckily I know very little about any of those, so I can ask very naive general questions to get people started. But please, people dive in and ask questions, and we'll just see how it progresses. So, one of the first things I'll start with the panel is just the idea of nutrition. It's such a difficult thing to actually test. And one thing that's always concerned me is how can we actually do a clinical trial if we're finding out that nutritional status of our mothers or our grandmothers is affecting how we go. How can we actually make proper recommendations for what we should be eating, and how can you do that? Do folks have any comments on those things?
So I think that it's become apparent that there's tremendous variation in metabolism between individuals, and that our recommendations in nutrition have been so crude that they cover individuals and hide the fact that we haven't recognized how to identify that variation. So when we make a dietary requirement, we figure out the average requirement and then double it. So we cover a huge amount of variation by doing that. In the future, some of that variation we'll be able to explain through genetic measures. Maybe further in the future, epigenetics will help us to explain that. And then there'll be other factors like body composition and whatever you could build in to individualize nutrition. And your question is, how do you do a clinical trial? I think the most important thing is to have some control of dietary intake and some measures, like genetic measures, that you collect so that when you get responders and non-responders in the clinical trial, you can go back and ask, was it because they had SNPs in certain pathways that made them responders? So I think we're obligated in clinical trials to start collecting some data so that we can retrospectively analyze and figure out why did some people respond and others didn't to a nutrient or a drug or whatever we're doing.
So that would be, you envisage an intervention trial, kind of a huge prospective study or some combination?
I think no matter what, so let's say you're doing an intervention with curcumin. You're going to get some responders and some non-responders. And to explain why that is, you may be able to go back from data and ask, let's say in SNPs, could you have explained that, some of that, from the SNPs they have? I think it could be in a prospective study. You've got people who seem to be having less heart disease and eating high levels of vitamins, and others who have less heart disease and eat high levels of vitamins. Why are they different? Again, you may be able to look at specific genetic or epigenetic marks. Right now, only the genetic are viable. The epigenetic are still too crude to be able to figure out what's going on.
Does anyone else on the panel have some comments on this?
I want to make, in the ideal, this is the ideal world where we will be able to do the genetics and the nutrition and do a sort of personalized nutrition. So that's the ideal world. I think that's a very important problem is how we implement that. I was commenting previously that we know what hyperphenylalanine does to, in a pregnant woman, does to the fetus, and it's still, when we know, and these women know, it's very hard to implement the notion that they have to plan pregnancies. This is a very important thing in development. They have to plan pregnancies and they have to follow a strict diet. So I think that implementations of all these ideal diets and interaction with genes will be a real challenge in the future.
Thanks very much. Anyone else on the panel? Christiaan, you had some ideas about clinical trials. Sure.
Well, I think number one, most nutritional studies have not been successful. I mean, I'm talking in geriatric research. So the challenge there is that, were those people deficient to begin with? Identifying your population is going to be, critical. And then the other challenge is going to be, if you're looking at, biochemical changes, let's say, insulin, glucose, inflammation, or whether you're going to look at the home run, meaning cognitive changes, physical function changes, those would be great. So, the problem is to identify cohorts to begin with that are deficient, and then you hope initially with some pilot studies to see some change. I think the key in the US right now, if you don't have pilot data on a clinical trial, don't even submit it. So you need a lot of funding from your university to show some effect on a primary outcome. And then you can power for a larger trial. So yeah, that's just a little intro.
Okay, thanks, Christiaan. Anybody else on the panel would like to?
I also would like to mention that you have to measure the status of the patient or the subject at the beginning. So I can tell this from the selenium field. There was a big study in which it could be shown that the selenium supplementation helped against cancer. And a following study, a very big study, the next study was stopped because there was no effect and even some adverse effects. And this could be, the reason could be that most of the subjects in the second study were already at the adequate or over adequate level. So they were very well supplied and they did not profit from an additional supplementation. Whereas in the first study, many people were at the lower level and they profited. And only those who entered the study with a very low level, they could be prevented from cancer.
So it looks like we're on a trial. We want to really know the patient group or subject group we're looking for and try and separate them out as much as possible. And also, if we're going to go for a bigger trial, try and get some preliminary data just to give us the powers to be that this needs something we can push forward. Anyone else on the panel?
I also just want to mention not to lose sight of what you're intervening with as well. I think a lot of the retrospective studies, there's been a lot of controversy because you're not necessarily looking at the same thing. So there's a lot of inter-individual variation in the person and the population, but also within the foods. So whether or not, what form you're using, if it's a food form versus a supplement form, what other drug interactions that may be coming into play, and other food interactions that are coming into play. And when you're thinking about nutrition, most people eat meals rather than individual things. And all those things need to be considered as well, which is difficult, very difficult to do.
Thanks.
Just wanted to add two more complicated things.
All right, go for it.
One is not just your mothers, but fathers now we're seeing have an effect on epigenetics, so in the offspring. And the second thing is remember that we're 10,000 times more bacterial cells in us than there are our own cells, and they'll have significant effect on how we eat and digest as well.
Okay. It'll get simpler by the end of the hour. Simplified.
One more comment. Of course, the importance is the timing of the study. When do you start to intervene? That's another huge issue. For example, we have a trial ongoing on moderate disability, so you have to identify. You just have to pick right at the time that they may have, let's say, a decline in cardiovascular disease. In this case, it was they're going to be either able to be walking or they're going to go into disability. And then you have a limited amount of money, and then you have 5 years to follow them, which is a lot of money. We're talking 20, 30, 40 million dollars to follow a cohort of, let's say, 2,000 people. So I think the time to intervene is very important as well.
Okay. So it's complicated and expensive. Anyone in the audience have any questions they'd like to raise for the panel?
I agree with you with the timing, but also what's important is the method used for analysis of the samples as well. I think when you do certain tests, everybody should have a same method to. It's sometimes very difficult to compare data in clinical trials when one uses, say, ICP-MS for zinc and one uses atomic absorption for zinc for measurement. And I think that's one thing that needs to be taken into account when we do clinical trials as well.
That's a very good point. The thing that always concerned me a little bit is that when I'm 80 or 90, how I behave in my 20s and 30s is probably going to have an unfortunate impact on that. How can we address that? We have to kind of make a best guess of what we should eat, what measures we should take during our lifetime. It's an impossible question to. Anyone want to take a stab at that?
So I think it's going to be before your 20s and 30s. So if you think about osteoporosis, it's what you build up very early in life. In my story on cognitive function, it's how you build the brain when most of the stem cells are undergoing proliferation, differentiation very early in life. And the impact you can have with an intervention later in life may be much smaller because you don't have the physical structure there to build on. You don't have as many stem cells dividing that you can replace damaged cells with. So it may be that what you do in your very early life really sets the tone for your whole life. And so if I had to say, if we were going to invest money in an intervention to try to result in a healthier population that lives longer, I'd say it's in the first 1,000 days of life, from conception onward, that you would invest your money because you get the biggest bang there. And going into 70-year-olds and asking, can I slow down cognitive decline, is going to give you a much smaller bang for your buck because you have very few anatomical neurons left to save, when if you could have built them up to twice as many early in life, you'd probably go longer before you run out.
Okay, so early intervention. Anyone else in the panel wants to follow that up?
I think it's, yes, we now know that there's a huge issue with child obesity. There's no indication for disease at that time, so I think early interventions are impossible in the sense that an IRB or there's no disease state at that stage. But I do think what happens in your first 10 years is critical later on. So I'm contradicting myself, but you're not going to be able to do clinical trials because there's no disease state to treat at that age.
Yeah, what I want but we have to consider there is a lot of evidence right now that what happens in gestation and during early lactation can have a very large impact on the risk for adult diseases. So we are all on this boat. So I think that it's very important to understand what's going on during pregnancy. That's why before I said probably in the future we are looking into planning pregnancies and optimum nutrition based on what we know about the patient's genes. And as we were seeing before, the brain in particular, when you have a process that is really tying into neuron production and astroglial cells, and if this timing and the processes of proliferation of apoptosis get imbalanced, we're going to have a brain that looks morphologically the same, but which connectivity and the impact on behavior is going to be major in later in life. So early.
I think me coming from a cancer center and talking about from the cancer point of view, also I will agree with what Steve initially mentioned. Apparently what they found with a lot of different cancers, it's very important that what you did in your 20s and 30s will make an enormous difference to what kind of cancers people come down later on in their life. So I tell people that try telling a 20-year-old that not to smoke, not to drink, not to do all those things that what we talked about. And immediately you will get a response, who the hell are you to tell me how I should run my life? But that is the time it makes a maximum difference. And by the time one reaches in their 50s and you try to tell them, and they will listen to you, but a lot of us it is kind of too late. So I think that what do you do in 20s, it seems to be very, very critical with respect to cancer as well.
Okay.
Well, of course, my emphasis is exercise, so I'm a little bit disappointed in this conference to see relative few of exercise intervention. And it's well established. A lot of disorders and diseases could be detected by exercise testing, such as cardiovascular disease. Secondly, exercise, some of the nutritional supplementation would not be effective without having exercise in combination with the supplementation. And third, I think that sometimes exercise would cause some nutritional disorder, and so I would say that for either young or aged population, I would like to see this group to think about exercise as a way to stress the body a little bit. It's part of the hormetic response, and review some of the necessities for nutritional intervention.
Okay. Anyone else? Any comments here? Any questions from the audience on what we've heard so far?
I would like to comment that there is a lack of data on absorption, metabolism, and based on this data, you could define the dose, the right dose. I mean, I don't see any data in this field, and I think this is very, very important. This is I would like to comment. Thank you.
Okay, so with the general problem of even if we have the diet or we're giving people, we don't know they may be absorbing differently, and we're not sure how that would go in a little bit with what was raised. About how much is actually getting to where it's needed. So, we've raised lots of interesting problems. The answers aren't immediately obvious, but we might have to at least move forward, because by the time we've solved these problems, most will also be dead. It would be interesting to think of what recommendations folks here have now on what diet and how we should approach these issues and what recommendations we should be making. Can we adapt this to people at different stages of their life? And how difficult is that in terms of, even in the industrialized world, where people have experience making recommendations?
I think I can add some comment. It's a very, very, very important point. But I think that before we talk too much about metabolism, absorption, bioavailability, we really don't know, because whatever we do in the test tubes is not relevant to what happens in vivo. And the kind of doses where you expose these few cells in culture for a few hours is very irrelevant to what happens in vivo, because the environment is different, the doses are different, the absorption is different, and so we really need to know more in vivo. And as it is, we do not that what is the right dose and what is not.
Yeah, I agree very much so with your point on dose. And if you look at a lot of the clinical studies out there that have looked at dose responses, they're very specific for a specific population. And most studies are actually done in young individuals, younger individuals, on how a dose, how the bioavailability, absorption, etc., is ongoing. So again, more of those studies need to be be done. Not to be negative, but if you come with a dose response study to the NIH, they will not fund it. Or you'll have very difficulties funding it because you're not treating anything. But it's very important. But they want the institution to fund those types of studies. I know I keep harping on funding, but we need more funding to study those responses in different population groups.
Question?
Yeah, just a comment. I enjoyed this discussion immensely. The wisdom and the knowledge is really profound. But I want to relate to what Lily G said earlier. And I'll say the same thing I talked about when I go to an exercise conference. I say you can't make the exercise prescription for a person of any age unless you know the diet. And I'll say the same thing here. If you're just talking about diet and not exercise, you're not talking about anything. Reality. The strongest data we have about longevity is your fitness level. And the freedom from heart disease is the same thing. It's your fitness level. So all these nutrients within the context of a baseline of physical activity is really what we want to do. We want to talk about a healthy lifestyle, and there's two components to that at least.
Okay. So,
it sounds pretty discouraging. Nutrition is pretty complicated. Metabolism is complicated. We've got microbiome that changes metabolism. We've got energy utilization and exercise that modifies it. So it seems like an overwhelmingly difficult story. When I went to university, they were just starting to understand how DNA and RNA and gene regulation occurred. It seemed like just as difficult a story that we would ever understand the intricacy of how genes are regulated. We still may not fully understand it, but now everything makes a lot of sense. And I think that comes about because a lot of people with fairly narrow views contribute a narrow story, and then they get pieced together as a bigger story that makes much more sense. And so I think the investment we're making in the kind of research we're talking about is the investment in those narrow pieces that can then be eventually pieced together to create a panoramic picture that suddenly makes sense. So today I understand a lot about gene expression I never would have dreamed I would have understood in 1970. And maybe in a little while I'll understand much more about the metabolism, aging, diet, interactions that right now seem extremely confusing.
okay, thanks. So we've got a long way to go, but we've gone a fair ways already, and we've got some optimism for the future. So putting that question back to the panel, what interventions or what dietary supplements, either in the form of particular foods or perhaps in particular supplements, if you had to choose one or two that would make a difference, people want to make a recommendation, I think it would be useful.
When I am asked what should I eat and should I supplement this with vitamin or another micronutrient, so I say no, because if you are healthy, you don't need it. We have all in our food, and we are living, thanks God, and so on, in a rich country, so we don't need supplementations. If you are have a balanced diet, so but if you are sick, you have diabetes or you have some metabolic diseases or some gene defects and suffer from, for example, vitamin E deficiency also, then you have to supplement. But this cannot be generalized. So you just have to take care that you have the recommended dose. So that one is good for the hurting.
So are there any situations where someone is ostensibly healthy, is taking a fully healthy, well-balanced diet, following all recommendations, and say in their 70s or 80s they might benefit by some supplements? Is that a possibility or something that we think is like the Bruce Ames kind of suggestion?
Yeah, okay, but there are enough examples that you have adverse effects if you have too much of all these supplements.
So I would view it in two ways. One, if you ate a perfectly designed diet, you would be fine. But if you're not sure you're going to eat a perfectly designed diet, then you want some insurance. And so I would buy insurance using a multivitamin that costs a couple pennies a day, that makes sure I'm getting recommended intake of 20 or 30 or 40 micronutrients, because I see low risk and I see, from taking it, I see high risk that I'm not going to eat the diet that I might do.
So kind of a safety net to make up for when you go for the hamburger rather than something.
Right, life insurance. And then the second thing is, I think if I were older, and I was looking at where biological function starts to create a problem with available nutrient. The best example would be B12, lower stomach acidity, you can't separate it well from meat, and you start to have lower B12 absorption. I think it makes a lot of sense as you get above 60 to take B12, because in its chemical form, it's not, you don't care about stomach acidity for absorbing it. So there are a few nutrients I would take, but I don't think you're ever, right now, there's much evidence that taking more than the recommended intake gets you anywhere, and it may give you trouble.
What about this mixture? You only have the vitamins and the trace elements. You miss all the other things.
So again, I think you could expand that insurance package out beyond those trace elements as things come up.
So
I
that
think try to
eating is
stay
no
within things that have a recommended intake rather than things that don't.
Yeah, I would go a little further. I would take some pro-oxidants rather than antioxidant. This could be two forms. One is exercise, as I always believe is the hormetic effect to induce the body's antioxidant defense. Secondly, a good point made this in your lecture is a lot of these so-called antioxidant phytochemicals are pro-oxidant, and their function is not to scavenge free radicals, but rather to produce a little free radicals to give the body stress and to induce some response, and mainly anti-inflammatory. And I believe very firmly from several studies in the past, such as ginseng that I conducted, and oats right now. We don't know what the metabolites of these compounds. And the function is not produced by the substance per se, but their metabolites. And I would like to see more study in the metabolotics and proteomics to see what's the functional ingredients of the compounds.
Question here.
I only want to answer back. We have to be very careful with flavonoids and polyphenols and antioxidant and oxidant actions, as we discussed the first day, to have the idea that very little of all these compounds is absorbed. So probably we don't have direct antioxidant or pro-oxidant actions. We have a large number of very targeted and specific actions of these compounds.
Okay.
A very short comment about this life insurance policy. It has been proved that suggesting supplementation has tremendous bad consequences on the way people feel themselves, because they are tempted to say, at least in Italy, they are tempted to say, okay, I get my vitamins, my minerals, so I don't need to eat well because everything is covered. And it's quite well proved that even if you identify the target molecule, say vitamin C, it's not the same to take it as oranges or whatever you want and as a peel. So I think that as a nutritionist, the first thing I should think about is proper nutrition. And I think that this insurance could be really expedient, really useful, only if we go for a personalized nutrition. There are some of us, who, probably myself, who should be suggested to take some pill. But not per se everyone should take supplementation, because it would not get to the point.
So again, I agree with you completely that it would be nice to have everybody eat a good diet. But my worry is that in reality, even those attempting to eat well don't. And 90% of the population isn't even attempting to eat well. So the question is, for the population, is it best? And I would say that the risk from taking a multivite each day is tiny. And I don't think it changes people's behavior at all. In our food and vegetable studies, we can change people's food and vegetable intake by half a portion a day by hitting them over the head with advertisements and information. And I doubt we change it by giving them a multivite.
Question here?
Okay, to comment, when I put in my lecture is to know the mechanism, the end mechanism through all these compounds are making a biological effect. I think we talked for years about vitamin E, and well, now we are in doubt about what is the real function of vitamin E. We try to minimize the effects of curcumin to just inhibition of NF-kappa activation, but we don't know. We perhaps know that it's doing something for our health, but we don't know how. And then at the meantime that we don't know how, we are not going to be able to define doses, to define the region, define if we need to combine with exercise, diet, just exercise or just diet. Then we need to know more. And my second point is that when you see the population, I think, for example, in the case of hypertension, about 1/3 of the population of the world is hypertense. And 1/3 of this population, that means 10% of the whole population of the world, doesn't treat or doesn't know about the hypertensive state. Then, to design a diet, to design changing the lifestyle is very important if we know that it's going to do something to this silent disease. And I think this is a factor that should be considered.
Okay. That's a good point. Christiaan?
Yeah, I think there's a huge potential for nutrition. And I'm still thinking of elderly individuals and aging. But you can hear from the discussion, there's a lot of confusion because we just don't know the answers. The US is very interested in doing trials again. Vitamin D is hot, zinc. There's a variety of funding mechanisms to test these things. So I think there's a huge potential. You need to identify the right population, which you can see from the discussion, you don't know how much, if it's even going to help, because those trials haven't been done. You need to do it for 5 years, you need to follow these people, they need to have an indication of some cognitive decline or some functional decline, and they need to show a difference with the placebo group. So the unfortunate thing is we need more funding, I keep saying.
Thanks. Question here?
Thank you. Responding to a couple of the comments by the panel, I've been in the supplement business for 37 years, so a combination of personal experience, which is more than national, as well as looking at data. The argument that somehow taking supplements will act as a deterrent or discouragement to good literature is not only not borne out, but it's absurd. In actual fact, people who take supplements tend to eat well. People who do not eat well don't even take supplements. They don't take care of themselves, period. They don't eat well, they don't take supplements, and they don't even exercise. So this is the argument that somehow supplements will distract from proper nutrition is a straw man, red herring, whatever, and it should stop already. It's counterproductive. It's absolutely false. The other thing about supplements is there are molecules such as CoQ10, lipoic acid. I mean, you're really not going to get that from your nutrition in particular. And then geographically, as Americans and Europeans, we're going to get very little to no substances such as tocotrienols in our diet. If you're from Malaysia, you will. You'll get it from your palm oil. But if it's not over-refined. So we live in a global situation today. We can source food substances from around the world. We heard a fantastic lecture from Bharat today about curcumin. And until this modern century, we were not going to have curcumin. Very, very little of it. It would have been incredibly exotic ingredient in food brought by ships over many months, sailing over dangerous seas. Today, we can extract it in India and fly it over and indulge in it. So the question is whether we should supplement. It's old, it's tired, cut it out. It's what we should supplement and how much.
Okay. So it looks like one thing could be that the people who are taking supplements are the ones who may still benefit, you would say, but they would benefit less than the ones who...
I think anyone actually benefits.
Okay. But obviously the ones who are on the worst diets might benefit more, but they're less inclined.
Very shortly.
Very quick.
As much quick as possible. I think probably because of my scarce English, you get the point. I think that the point is that when we go for policies, so if you want to improve the quality of the nutrition of our population in USA, in Italy, or wherever else, we cannot suggest supplementation. We have to suggest and push for good nutrition. Then, I have nothing against supplementation per se, but what I want to know if I really need either, as you perfectly pointed out, people who take supplementation usually already eat well. So it is this raining on a wet globe, on a wet floor. So it's useless. In the majority of cases, take supplementation is useless. The point is that I would like to be supplemented if I need to be supplemented. And this is policy.
Poison is hysterical, and CoQ10, tocotrienols, lipoic acid, probiotics, you're not going to really get them from your diet. Please listen carefully and don't come from a point of bias.
Okay,
but
I think we're going to move this question on and summarize this.
Hi, I'm John Berger. I have 2 questions for Dr. Aggarwal. In your talk, you said that NF-kappa B is in the center of an inflammatory network and that it can take up to 30 years for cancer to develop as a result. And what I want to know, first of all, is does this happen 50 times faster in mice, or are mice a really bad representation or model for human cancer development from inflammation? And the second question is, how much turmeric should a person take every day?
I think those are both very good questions. The first one is mice a good model or a bad model for human cancer? And the answer is, very simple answer is absolutely yes. So far, I do not know of a single drug that worked in mice, did not work in human, or did work in human and did work in mice. So in other words, whatever we are doing in mice, very, 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 very rarely translates to you. Okay. So I wrote an article that the models, today is the model for cancer treatment that we have available. They are not really models, they are models of cancer research. They are absolutely telling us nothing that what happens in man. And that's why we don't have a cancer treatment as it stands right now. And if it continues the way we are going right now, I'm not very optimistic. Okay. So that's the answer to your first question. And the second one regarding curcumin, just to give you a normal idea, I mentioned some of the clinical trials that 150 milligram twice a day, and that's the common anybody who sells curcumin as capsule is a 500 milligram capsule. So 150 milligram twice a day, the clinical trials indicate, and this is diabetes, and this is placebo-controlled, double-blind, that it is enough to down-modulate TNF, IL-1, IL-6, malondialdehyde, and endocrine 1.
Okay, that's it.
So the average.
I think you're answered the question, so I think we'll move on.
The average dose that a normal Indian is around 150 milligrams, just to give you.
Rami Lambrani from the Department of Pharmacy, University of Rennes. I'm going to ask you a question which is really fundamental, but I think it's very important and somewhat tricky as well. What I want to know is, we today, despite of all the advancement in molecular biology and analytical techniques and all, we could have reached the transcription machinery of the cells. We could have find out what's going on in micro and in nanoparticles inside nuclei of the cells. And with all this research, finally we are reaching to the fact that what has been done before with our ancestors, with our parents, with their nutrition and with their more physical activity as we conduct nowadays was more correct than administration with drugs and commercialization of vitamins, instead of just asking people to go for a proper diet, which is more than even 85% vegetarian, and reducing the meat and the food which really induces and teases the antioxidant defense mechanism of the body. Why not to change to vegetarianism? First of all, I want to know actually your point of view on that. And secondly, is that in universities normally where we conduct this researches and all, we find out that finally, as has been mentioned in the first day of the meeting, in a presentation, I don't remember the title of the presentation, but they just mentioned that we had 3 great changes in human nutrition from 10,000 years ago to the date. And 2 of these changes has been done in less than a century ago. That means that this nutrition brings about such a high oxidative stress in the body, which actually the normal antioxidant defense is important to respond. So we have such pathological complication like cancers, which we never had before. And even right now, if you look at the Food and Drug Administration of the United States statistics, we will find out that so many of these complications could be terminated by nutrition. For example, yeah, that's it. So why not to something practically I'm talking about? Why not to induce antioxidant defense system through polyphenols and through physical exercise? But
okay, I think
you got the point actually. So I don't just want to make it so long. So.
Want to comment on vegetarianism?
I would like if a pharmacist could answer this question first of all, please. And sorry for the long question. It is my concern actually. So that's why if I just begin to speak, I can't terminate it easily. Sorry.
We'll terminate for you. Okay. Does anyone want to pick up the idea of what about one of the ideas coming up, the idea of vegetarianism versus the meat eating? Well, that's a whole separate one.
Can I just sort of take a step back here? I actually sit on the Federal Steering Committee for the Dietary Guidelines for Americans, and I'm actually the co-chair for the Committee on DRIs of the U.S. government. So I've had a lot of experience in looking at guidelines, what we say to populations, what they do. First of all, the dietary guidelines are based on what we would tell for a healthy population. They're not therapeutic. They're just guidelines for a healthy population. When you get into the therapeutics, you're going into clinical proposals and things, and we don't do that in the dietary guidelines. We've been devising these guidelines, which are general, to people to follow healthy diets, and most Americans don't do it. I'll speak for America. Most Americans don't do it, and the reason they don't is they have so many other priorities that are conflicting with this. This is not an issue that is really on the top level for them. For all of us who are interested in health and who are interested in aging and well-being, it is an issue, and we do follow them. But if you go out to the general public and the general population, they have so many other things that they're worried about, that just getting fed, just getting food on the table for their kids and their families that they know that they will eat and be filled is important. We've tried what we can, we've tried the negative messaging, it doesn't work. People don't want to hear no. We're trying to go back to some positive messaging, but it's not as simple as just tell everybody to eat a vegetarian diet and they'll do it and they'll follow it and they'll have health. There's so many other things that people are worried about right now.
Okay, so people don't necessarily do what you'd like them to do. Anyone else on the panel want to follow those things up?
I think the only other thing I want to state that Eskimos, they never get cancer. If that is of any help to them.
They are very active.
I just wanted to pick up on the idea that the diseases that we have today are because of our diet. It's not necessarily the case. And in many cases, things like Alzheimer's, we just live long enough to get Alzheimer's. If you look at the rate of Alzheimer's incidence per 5,000 people, it's about the same as it's been for many, many years. There's just many more people living to be 70, 80, 90, old enough to get Alzheimer's. We just finished a study at USC and a few other centers that actually looked at mummies, at Peruvian mummies and some Egyptian mummies, and was looking at the incidence of coronary artery disease. And the bad news is that coronary artery disease was found in every one of the mummies they looked at to varying degrees. So that's not a new disease either. That was around 5,000 years ago. I don't know exactly how much of these things are dietarily related, but I think a lot of it just we're living so much longer that we live long enough to get diseases that are problems for us. I'm not sure it's all diet.
Well, Calvin, I want to second that along with physical activity. It's the whole lifestyle. So it's more than just a diet, it's the exercise, it's the stress. There's many things that are factoring into this. So just to focus on the diet would be foolish. You need to look at the whole lifestyle.
Okay.
Calvin, I like the mummy story, but those are probably people not exercising or doing much. Would that be true?
No, actually, most of those were Peruvian mummies, and
so those were inclined to do everything.
Yeah,
okay.
this is in a society where people regularly mummify. They don't wrap their mummies, so that it's a little different terminology. But they keep dead people as part of the home, and those people were the ones in most legal studies.
So they weren't necessarily very rich.
They weren't necessarily very rich. They were regular, ordinary people, most of them.
One last question up there, then we're going to
Yeah, I just have a really quick question. I'm from Australia, and in 2009, mandatory folic acid fortification came into play. And since you're a panel of international speakers, my question is, what are your views on mandatory folic acid fortification as a way of, minimising the prevalence of neurotube defects from unplanned pregnancies, when we know that folate has a role in DNA synthesis and someone has precancerous cells that can accelerate the growth. So what are your views on mandatory folic acid fortification?
It would be a simple one to finish off. Who wants to take that?
Well, initially the thought for the U.S. anyway, fortification of the grain foods, that it would prevent neurotube defects, but it actually also had a very positive effect in the older population. But recently we've been finding that there are people that are over-responders or under-responders, and there's an increase in cancer with that. So it may be benefiting some people, but it's probably not benefiting everyone, and there's some people that we're actually very concerned about.
Okay, I think it's a good point. It's benefiting some people, but not others, and it's something we're concerned about. There's a good summary, really, of where we've got to. So I expect by the end that we fully understand everything about nutrition and how to have the optimal diet, but we haven't quite got there yet. But please join me in thanking the panel for a very